Okay, so let's get going. Chemical restraint. Goals and objectives of this. There are some very basic goals and objectives. I think you'll kind of understand what I'm talking about. The main one goal and objective is to not hear the term 5 and 2 ever again. I think you guys may know that when I hear this, it kind of makes me cringe for a couple of reasons, and we'll kind of go through why that is. But I want you to gain a better understanding of the medications you're using so that we can kind of have a more specific, tailored approach to chemical restraint. Again, when I hear you guys say that, I kind of cringe and I get that Dr. Cox moment and I say, no, Bambi. And the reason for this is I want us to be a little more specific about what we're doing. First off, 5 and 2 isn't what it used to be. When I trained so long ago, 5 and 2 was 5 of Haldol, 2 of Ativan. So if you're just yelling out 5 and 2, you may actually be getting a different medication depending on what the nurse perceives as 5 and 2. And that could have some deleterious effects. Also, if we're using stuff like Versed, again, 5 and 2 is kind of what we say in emergency medicine, but if you're using 5 and 2 with Versed and you're using 2 milligrams of Versed IM, you're probably underdosing the medication. So it's kind of nice to have those quick things to yell out, shotgun approach, but I think there's some downsides to it. I also don't like to use 2 or 3 drugs when you could potentially only use one. One of the things that really frustrated me in residency is when we'd be on rounds and one of my patients would be agitated and someone would say, oh, just 5 and 2 them. And now the person got 5 of Haldol, 2 of Ativan, and it was 4 more hours until I could actually talk to the patient. Or now the patient had respiratory compromise because they had multiple medications. The other thing I really never want to hear you say is B52, because now we are adding a third medication onto a regimen that's probably not necessary and completely snowing this patient for a long period of time. If I hear you say that, we probably just won't talk the rest of the shift. So that's my first goal, is kind of get that shotgun approach out of your mind. The next one is to pump the brakes before we go to tube someone. It's actually extremely rare that you need to tube someone due to agitation if you use the right sedation and chemical restraint approach. Sometimes they do need to be tubed. Rare cases, the patient is just so violent or they're refractory to treatment, or you're just trying to facilitate a workup and you do actually need to intubate them. But remember that intubation has a lot of downsides. It takes up beds. It takes up ICU beds, more importantly. It takes up ventilators. There's the real cost of aspiration pneumonia and ventilator-associated pneumonia and sepsis. And many of these patients, they just need a workup and they can go. And when we intubate them, we know it's unfortunately rare that we actually extubate patients in the ED. We should probably do it more than we do. But often these patients just end up getting admitted to the ICU over the weekend and have 3 days in ICU bed really for no reason. So I really want to think about pumping the brakes before that we run that patient down to recess. Obviously, it's going to be different depending on where you practice the next couple of years. At UF, we have all hands on deck. We have lots of people and resources. But I think while you're in residency, it's good to get into the behavior of really trying to avoid rapid intubation of these patients if they don't actually need it. So the approach I want to kind of pass on is for you to gain control, then reevaluate the situation once you gain control, and then fine tune your treatment. So again, getting away from the shotgun approach and getting more toward a fine-tuned treatment for these patients. There's kind of 2 broad disease entities I'm going to talk about. The first one is going to be psychosis. So this can come in many different forms. There's just that kind of generally psychotic patient that comes in. And the other one's going to be excited delirium. Now, these terms overlap each other immensely. Excited delirium is kind of a broad term. It's a very controversial term. It can include psychotic patients and psychosis, but the ones I'm talking about are the ones that are really kind of hopped up on the sympathomimetic, maybe on PCP, or just jacked up on spice or something else and coming in very violent. So those are the kind of patients I want to divide out a little bit and talk about. So when these patients come in, we need to choose a medication. And there's obviously going to be lots of different things that we have to think about while we choose these medications. And some are going to be the onset. So is this fast or slow onset? It's going to be obviously very important, especially when you're now taking resources of security guards and other staff to restrain the patient. Well, what's the duration? So is this patient going to be snowed for hours, or do I expect that they're going to be awake again in 30 minutes? Very importantly is route. Often these patients obviously don't have IV access. So we're going to have to figure out how we're going to get the medication in this patient. And then side effects. I kind of like to use the term side effects with a lot of these meds and not adverse effects, because a lot of things get chalked up as an adverse effect when it's not actually a dangerous side effect. So again, when you're thinking about things, try to divide out what is actually adverse and what's just a benign side effect. So when I get this patient here, and I've had this patient been in this situation many times, and I'm in a situation where this is a very violent patient, and I want to gain control. All these things run through my head. Again, is it fast or slow? How long is it going to last? What's my route? What are going to be the side effects? What are going to be the adverse effects? It's all running through our head. It's a lot of things to think about and process while we make this decision. Now, obviously, we like to have what I would call perfectional, and that would just be the perfect drug we could possibly have for these patients. And what would make this drug perfect is that it goes on right when you give it. The duration is exactly how long you need it. There are no side effects, and you can give it any route you possibly want to give. Now, the reality is we don't have this medication, but we can take kind of the benefits of some different medications and tailor our treatment and come up with a good regimen for ourselves. So looking at our general options, and I added etomidate in there in the picture, and I meant to actually take it out because we're not going to talk about etomidate, but I want to divide these general medications into 3 different classifications. So we're going to have our dissociatives, our sedatives, and our antipsychotics. And those will be the 3 main classes that we'll talk about, and we'll kind of, with each one, talk about a general approach. So dissociatives are going to be ketamine in particular. Our sedatives will mainly talk about midazolam and lorazepam, so sticking to the benzodiazepines. Obviously, there are other ones, are barbiturates, which we rarely use for this situation. Antipsychotics, we'll talk about haloperidol, droperidol, a old kid on the block that's now back in style, the new kid on the block, and ziprasidone, also known as Geodon. So first off, ketamine. It is no secret that I like ketamine. It will likely be on my gravestone that I love ketamine. I don't love it because I'm trying to be a cowboy. I don't love it because it's a sexy thing to talk about. I love it because for the past probably 5 or 7 years, I've really taken a deep dive in literature, and I've used this extensively. Toward the end of residency, I made a personal decision to use the hell out of ketamine so I could be very comfortable with it, because I thought the side effect profile and the pharmacokinetics were so beneficial compared to other medications. So I do use it a lot, and it's for good reason. I've looked at literature, and I'll talk about the benefits of this medication over other ones. But again, there is personal bias in this. I will be the first to admit that, but I think it's for good reason. So ketamine is important to understand. It's not exactly a sedative like our other GABA-mediated ones. It's a dissociative. So the way I like to describe this to providers or lay people is it takes a pair of scissors and it cuts off the rest of the cortex from the basic brain, the basic brain stem. And so the patient just dissociates. They're cut off from reality. So it's a little different mechanism than our other sedatives that we use. The general dosing is 1 to 2 mg per kg IV dosing. We'll talk a little more about this in a second. And then if we're doing IM dosing, it's 4 to 5 mg per kg. I always hear some issues with this. People can't believe the big doses folks are getting in the field or in the ED. Oh my God, they got 500 milligrams per kilo or 500 milligrams. Yeah, that's a right dose. And sometimes it's actually underdosing the patients. And the pharmacokinetics of this medication, how it works, it's safe to actually go higher in these doses. So to kind of put that in perspective, we always talk about the K-hole. And so the K-hole is that when that patient fully dissociates, that's where you want that patient. Again, they're fully dissociated, they're fully cut off from reality. They're not receiving much stimuli, and they're just kind of in their own little K-hole. So when we see areas of the K-hole, we see there's different levels. If we go back up toward the surface, we have what's called subdissociative dosing. This has become a hot topic in the past 5 or 10 years, and this is what we call pain dosing. So the whole point of this is it doesn't dissociate the patient. And I put the wrong dose up there. It's supposed to be 0.1 to 0.3 mg per kg IV. IM dosing isn't as well understood. And again, this is supposed to sub-dissociate. The fact of the matter is this often puts people into partial dissociation. So once you start getting up more toward the 0.3 milligrams per kilogram, patients will often report some sense of unease or detachment from reality. So do know that these patients do actually dissociate a little bit. It is best to actually run this dosing over 10 minutes, put it in a 50 or 100 cc bag and run it over 10 minutes is actually the best way to give this medication and decreases the amount of dissociation the patient gets. Dissociation isn't dangerous, but patients may say, you know what, I don't want to experience that again. If we go all the way down to the bottom, which is our goal with ketamine, that's our full dissociation. Again, 1 to 2 mg per kg IV, 4 to 6 mg per kg IM, and beyond. The reason I say and beyond is because ketamine has a ceiling effect, or in this example, I guess more of a depth effect when we talk about the K-hole. You reach that full dissociation, you can't go beyond full dissociation. And that's one reason I like the medication. If you push yourselves into higher limits of benzodiazepines or propofol or barbiturates, you can cause things like respiratory depression. But once you get your full dissociation from ketamine, unless there are other drugs on board, that's what you're going to get. And by increasing your dose, you just prolong the duration of those effects. And again, that's a reason I like this medication. There's case reports, and actually recently in our own department, of accidental overdose, 5 to 10 times the dose, and patients do fine. And what it does, it just prolongs your effect. So often you may see me come back behind 10, 15 minutes later, give an additional dose to a fully dissociated patient. And the reason for that is because I want to prolong the dissociation. So again, that's a reason why I like this medication. Where we have to be careful, and the mistake I personally believe a lot of the providers do, is they get into this dangerous zone of partial dissociation. And everyone has their own opinions on this, but if you look at the pharmacokinetics of the medication, and just from experience, if you don't fully dissociate these patients, this is when you get in that bad zone of them freaking out. They're starting to see the monsters at the bottom of the K-hole. They're starting to see ponies and zebras and elephants flying around. And they really start freaking out. And I remember seeing this in residency. I gave someone kind of a half dose ketamine for a procedure, and she started flipping out because she suddenly went blind. So the problem with this half dosing or low dose ketamine is that you can cut off some of the synapses. But the patient can still fully respond and still understand and take in what's going on around them. So it can get pretty scary for the patients. There are reasons why we would want to lower dose our ketamine, but just have a good reason for it and know that the patients may experience what we call that emergence phenomenon of partial dissociation. And there are also patients that are just ketamine tolerant. So really, if you give them the full dose, they still are in that partial dissociation. They're fairly combative. They're starting to freak out. So do know there is a subset of patients. It's fairly rare, but they actually are a little bit ketamine tolerant. Often patients have a history of some alcohol or drug dependency, but they don't have to. For both of these, the partial dissociation, the ketamine tolerant, the real treatment is to give more ketamine, honestly. If you end up half dosing or give patient full dose and they are starting to really get worried and scared and looking around and starting to move and stuff, give them more. I wouldn't at that point go to a second sedative or second agent. I would give them more and try to push them into that full dissociation. And if that doesn't work, go to another agent. But this is, if I ever bring up the idea of half dose ketamine, this is why I usually take issue with it, because it's not so much dangerous, but that's when all the time I hear patient or providers say, oh, I don't use ketamine because one time I gave it to the patient, had a bad experience and they freaked out. Well, the fact of the matter is they're partially dissociated and we just need to give them some more to push them into full dissociation. This is a medication I don't like providers to get a bad taste for just because one time they had a bad experience, because it is a very good medication. When we're looking at kind of the pharmacokinetics, it's kind of what I like to call a turtle bunny. It's kind of in the middle of fast and slow. IV goes on pretty quick. You'll start seeing effects in 5 to 10 minutes usually. IM's obviously going to be a little longer, but it's pretty rapid. It's not as rapid often as midazolam. Most studies show it's around there, but sometimes it might take a little bit longer. It's pretty quick. So IM formulation, often 30 minutes, 45 minutes, the patients are starting to emerge and wake up. The full effects will take longer to wear off. If we want it to last longer, IM is obviously going to last longer. Also multiple doses. Like I said, so I had a patient last night with Grzinski and she was completely out of control. And so the first thing we did was gain control. We gave her 100 milligrams IV. That put her into full dissociation. And then 5 or 10 minutes later, came back, gave another 100 milligrams. Again, the reason for that was just to prolong her dissociation. You can really give it any route. We're rarely giving it intranasal, but you can, but often it's going to be IV or IM. And with all these medications, we can also give intraosseous. Remember that. I have had patients that they have 6 guards on top of them in the hall, and they're so violent that I can't get to a good spot for an IM administration, or I don't want to stick a security guard with a needle. I'll go down to the tibia and put a IO in. Don't feel scared to do it. If the situation warrants it and your staff is in danger, these medications can go in just as an interosseous and usually have the same onset as IV formulations. So the main reason I like ketamine is that all these other medications slow people down. You'll see these patients kind of slow down, everything slows down, respiration slow down, but they're just kind of groggy. Ketamine makes people stop. And that's what I want. I give ketamine to my violent patients because I don't want them to slow down and just punch slower. I want them to stop. And that's what ketamine does. And that's the reason I like it. Anytime I'm teaching about it, I just explain that it takes you down to your caveman brain. Again, it cuts off your cortex. So it just protects those basic functions of the brain. It protects your respirations, and it in general protects your cardiovascular function. Patients can have short periods of apnea I'll talk about. If they have other meds on board, especially benzodiazepines, they can have respiratory depression, but it's much rarer than the other medications. It's not so much cardioprotective. It just doesn't have the same deleterious cardiac effects as other sedative medications. So don't think you're going to completely protect the patient's cardiovascular status. You still can get drops in blood pressure. In general, the side effects are going to be tachycardia. Again, something we always worry about. I hear this a lot, especially excited delirium patient. They come in and they say, oh, well, their pulse is 160, so I didn't want to give ketamine. Most of these patients are on the younger end of our patient population, often not with other comorbids. And it's okay to make these patients tachycardic. It really is. The patients you don't want to is if you know they have bad CAD, or obviously if they have an aortic dissection. We had a patient we were intubating last night who was hypotensive. And the reason we didn't get it because their core temp was 108, their environmental hyperthermia. And so to Ryan and I, it probably wasn't a good idea to give another slug of sympathomimetic medication. So there are reasons why you wouldn't want to use it, but it's okay to make these patients a little more tachycardic. And honestly, when you see these patients, often when you fully dissociate them with ketamine, their heart rate actually drops. Because now you've taken away that stimuli they're getting from whatever med or drugs are on board. So you actually sometimes see a decrease in the heart rate. But again, tachycardia in general is not dangerous. The other thing we worry about is emergence phenomena. And this is a reason why I think most providers who don't use ketamine, this is the reason why they don't use it, because they had one bad experience where a patient got out of control and they said, I'm never going to use that medication again. And I don't think that's a good behavior to get into because of the benefits of the medication. If the person starts to emerge or have some agitation while you're dissociating them, again, give more ketamine, because they're just not fully dissociated. And if you're giving a good dose and they're still not dissociated, they just may be tolerant, and then you can try another medication. If they're starting to have agitation emergence when they're coming out of dissociation, so you've done the reduction or you've done their workup and you want them to start waking up to go to jail or get discharged, whatever, then use another medication like midazolam or maybe some propofol to go ahead and just get them through that episode. It's not dangerous and it will resolve. This is the issue I have with adverse effects or side effects. A lot of studies show this as an adverse effect, and they say, oh, there's a 40% adverse effect rate. Well, that's emergence phenomenon. It's not dangerous. It's unfortunate for the patient. It's not comfortable, but it will resolve and it doesn't lead to any long-term morbidity. Some real issues that people worry about for good reason: hypersalivation. So yes, this can be a side effect of ketamine. It's fairly rare and it's very rarely clinically significant. If you look at the evidence, it's very rare that's actually clinically significant. Currently not recommended to prophylactically give atropine or glycopyrrolate, but I will give it sometimes if I may be using ketamine for a procedure that's an oral procedure and I really want a dry oral mucosa, or the person's already hypersalivating for some reason. I may either use atropine or glycopyrrolate or just use a different medication. But no, this shouldn't be a reason why you across the board don't use ketamine. Another adverse effect we worry about is laryngospasm. Again, very rare and very rarely clinically significant. It's hard to find many cases of clinically significant laryngospasm, but it does happen. Again, in my opinion, this shouldn't dissuade you from using it across the board, but it is good to have treatment options in the back of your head. So anytime you're going to use any medication, you should think to yourself, how am I going to get myself out of this if it doesn't go well? So there are some things we can consider with laryngospasm. So if the patient starts having some sort of stridor or difficulty breathing, or honestly, any silent chest, if they have complete laryngospasm and can't move any air, you need to already have some treatment issues in the back of your head. So first off, honestly, stay calm. This is anytime I've seen something like partial laryngospasm, the entire place starts freaking out and people are running and throwing bag valve masks and stuff. Just stay calm. That's number one. Remember, you're leading the train on this, and you need to be the example for the rest of your team. The next thing you can try is laryngospasm notch. So it's kind of where most of us would do a jaw thrust and put pressure to try to wake a patient up. Same type of area, putting some good amount of pressure there can possibly actually relax the laryngospasm. Evidence on it isn't great, but it's a fairly benign procedure, and you're actually going to be putting your fingers there anyway to do a jaw thrust. So my first step would be put pressure on that notch, give a good jaw thrust. And if it's a partial laryngospasm, this may get you enough for you to just kind of wait it out, allow the medicine to wear off, and then reapproach the situation. If it doesn't seem to be abating, but your O2 stats are still okay, there are some options. You can give some sedation. You can give propofol, kind of procedural sedation dose. You could consider something like midazolam and repeat those doses as needed, as long as they're protecting your airway. There is some evidence for low dosing of succinylcholine and kind of 0.1 mg per kg, and then possibly bagging them through it. Again, if I'm at this point doing this, I'm probably rolling down to recess. I may consider the sucks and just be ready to intubate, have this kind of a bridged intubation. If it works, great. If it doesn't, we're going to go ahead and tube the patient, kind of thing. But just know there are some medication choices that you have to possibly relieve the laryngospasm. If they are dropping their sats and they're critical and they're going down the tube, then you just go ahead and get ready and intubate them with your normal RSI, because that's just not something to mess around with. And obviously, knowing that they're laryngospasm, it should relieve with the succinylcholine, but it may not fully relieve. So just having your backup plans and your plan A, B, and C for intubation. Also known that ketamine is not contraindicated in schizophrenia. I hear this a lot. I actually heard it last night, and it's not contraindicated. There is evidence that subdissociative doses of ketamine do cause schizophrenic-like effects in healthy patients and patients with a history of schizophrenia. So could you possibly exacerbate underlying schizophrenia? Yes, you can, but it resolves usually in the first 60 to 90 minutes. It completely goes away. So it's not dangerous. But if I have a patient who has known schizophrenia and I'm pain dosing them, I'm probably going to avoid ketamine just to be nice to them. But once you get into the full dissociation dosing, those effects should go away because you're fully dissociating the patient. But do know they could easily have a worse emergence phenomena. So you may want to be ready at the bedside with some benzodiazepines or propofol. So one issue that always comes up when we're talking about EMS protocols or ED protocols is people say, well, people who get ketamine get intubated more. This is a big deal a couple of years ago when JFRD put ketamine on the trucks. And within the first week, I believe 2 or 3 patients got intubated because they came in at GCS 3 to 5 after ketamine. And that was the main reason they got intubated. And that's the problem we see. It's not that they're intubated often because they lost their airway. It's just they're intubated because suddenly a patient's throwing up GCS 3 and we don't know why. We don't know what's going on. So it's important to kind of look at all the literature. And there's been a fair amount of studies on this, not great studies, but mainly pre-hospital literature and a couple of ED articles as well, seeing, well, what is the effect of ketamine administration and intubation? And if you kind of pull all the data together, there's a couple things that come out of this. First off, concomitant administration with benzodiazepines usually leads to more intubation. So these patients who in the field got ketamine plus Versed or ketamine plus Ativan usually had a higher rate of intubation. And often the reason was for low GCS after administration. So that's the only reason they're getting intubated. They showed up to the ED. The provider wasn't really sure what was going on. They had a GCS 5, so they went ahead and tubed them. And it's kind of just provider discretion. It was interesting. There was a study in 2018, and of 28 patients in the study who got intubated, half of them came from a single provider. So you can see how that was huge provider discretion if there's one provider that was intubating half the patients in the study. But there is very little evidence that intubation is actually due to hypoxia or loss of airway. most of these cases you look at, if you tease it out, you realize the patient isn't actually losing the airway. Now, to put this in perspective, it depends on where you work. Again, in our ED, we have all hands on deck. We have lots of resources. We're able to manage these patients and take time. If I'm at North, it's a very different story. If you're out in the community next year, it's a very different story. If you are 1 or 2 docs and you have 20 patients to see, you're going to intubate this patient and move on because you can't be at the bedside the whole time. So that's completely understandable. But do know it's usually just due to those factors. And what I hear a lot is that they had a low GCS, and that's the worry of the provider that, oh my God, they're GCS 5. But remember, that's your goal. That's why we're dissociating these patients. I want them to be a GCS of 5. If they're not, then I haven't probably used the right dose of ketamine. So just to remember, that is the expected effect of the medication. So if that's what you're seeing, then you probably properly dose the medication. So now we're just worried about, is the patient protecting their airway, or is there another reason I have to intubate? And I wanted to add this last study, and this is Josh Newell. You may remember him. He was a pharmacy resident last year. He moved on to better places. But we actually did a study on as part of this study that's trying to get published right now. It's called Evaluation of Safety of Haloperidol and Benzodiazepines versus Ketamine, the Treatment of Agitation in the Emergency Department. And what he did, essentially did a search of all the EPIC records and looked at all the patients who got either Haldol plus benzos or ketamine and tried to see, did they get intubated more or did they get sent to the ICU more? So this is based on our own patient population. What he found was of 187 patients, they found about half that got Haldol plus benzos and half that got ketamine. And what came out of it was that ketamine increased mechanical ventilation and increased ICU stays. So they sent this to me, and I immediately went through some of the stages of grief because I'm a fan of ketamine, and in my own population, I was seeing, okay, this is causing more ICU stays and more intubation. But again, knowing the literature of ketamine that I've seen and kind of the short sides of all the literature, I wanted to kind of take a closer look. And the pharmacy folks were very nice in dealing with my constant request to look at this data a little closer. And I'm really glad we did, because the problem was in the methods, and Josh did a very good study and did it right. But the methods, essentially, all it did was do an EPIC search for what patients got ketamine and then who ended up in the ICU. So it was hard to tease out the details of each case, which is a good thing to do if you're a researcher, to go back and really look at it case by case. So when we did, we found 13 cases in which people got ketamine and then either mechanical ventilation or ICU. 3 of those patients were for refractory agitation. So what that meant is, despite the ketamine, they were still agitated. And that's why they got intubated, or that's why they went to the ICU. So it's not that the ketamine had an adverse effect, it's that they actually weren't sedated enough. 2 patients actually got ketamine after the outcome. So they got intubated and then got ketamine. 3 patients were intubated specifically for a procedure or for a CT. So we'll commonly do that in trauma in our sick patients. And then 1 patient was put in the ICU for a reason other than sedation. When you take all those patients out, you only have 4 patients left that had a possible association. And when we look at all those, it was kind of murky as well. 1 patient received ketamine plus benzodiazepine, so had a little bit confounding there, and was extubated an hour later. So pharmacokinetically, it doesn't seem to be due to the meds. Another patient intubated 2 hours after administration. Another patient sent to the ICU 6 hours after administration. And another one intubated an hour and a half after administration for an undocumented reason. So when you look at all these cases, it's a much lower chance that it was actually due to the ketamine administration. I know this is kind of fine-tooth comb picking out details, but again, these are the studies that, when read incorrectly or reported incorrectly, can really do disservice to any medication. And Josh and the other researchers were very good about going back and putting in the discussion of the paper this information, so that people reading this paper and making decisions about their department can have the right information. And on this topic, often I want you to know that often these patients will actually experience some apnea, and it usually is about 15 to 20 seconds. And with that, they'll sometimes get a dip in their SaO2. This is another situation that you need to kind of pump the brakes, take a step back and look at the patient. If you push ketamine a little too fast, you have a higher chance of apnea. Even if you push it slow, you will sometimes get a very temporary apnea. And what usually happens is you see them actually trying to make respiratory effort, and their body's really not allowed to happen. And about 15 seconds later, they take a deep breath and start breathing normal again. And in that time, your O2 sat will often dip. Sometimes the low 80s, it'll dip. But if you look at that patient, especially if you have them on the oxygen and they're now taking full, deep, normal breaths, give it time. That O2 sat will lag. About 20 seconds later, it'll pop right back up into the high 90s. So that's my only teaching point with this. If the patient continues to be apneic after that time period, 15, 20 seconds, you probably need to do something about it. Usually it's just a little jaw thrust, possibly bagging, but usually just a jaw thrust. But 9 times out of 10, the chest starts rising again. If you have oxygen on them, just give it a little bit of time, the O2 sats come back up. So my practice for this, again, possible jaw thrust if we need to, some stimulation for the patient. And in most patients, I do this in chemical restraint, including the patient last night. I'll usually put them on 10 liters nasal cannula high flow. That's just my personal practice. That does some nitrogen washout. It gets some positive pressure in the airways. And then I'll just do that for the first couple minutes, just to kind of pre-oxygenate in case they do have that apneic period. Any questions on ketamine? Because that was the ketamine part. Before I move on, speak up. All right. So moving on to benzos in the next class. So we'll talk about midazolam, also known as Versed. The main dosing, 5 to 10 mgs IM, 2 to 5 mgs IV. In general, very fast medications. This is the big benefit of midazolam. It's pretty rapid in any route you're going to give. A good amount of literature is showing that it's rapid, and we'll talk about that in a little bit. It's pretty quick offset, which I like as well. I don't like these patients to be snowed in my initial administration. Again, my initial dose is to gain control and then kind of reevaluate the situation. Usually I don't want to snow them for 4 hours right off the bat. It can be given really in any route. And the main side effects or adverse effects that we know about midazolam and all benzodiazepines that can lower your blood pressure and also cause respiratory depression. So also in that class is Ativan or lorazepam. Our dosing for this is 2 to 4 mg IM or 1 to 2 milligrams IV. Compared to midazolam and most other medications, it's going to be much slower onset. So often you're waiting 20, 30 minutes till you see a good amount of effect. You'll start seeing effect earlier, but to get your full sedation often takes a little bit longer. It lasts longer too. Often a couple hours these patients are snowed, especially if you give them a good dose IV. Much like midazolam, it can be given really any route. And it's going to have the same side effect and adverse effect profile as midazolam as well. Going into antipsychotics, I'm going to talk about these two classes and then kind of compare them. So our first one, our tried and true haloperidol, also known as Haldol. We give this on a daily basis, if not many times a shift. In general, our dose is going to be 2 to 5 mg IM or IV. I have the asterisk there because it's technically not approved for IV administration, and you'll see that on the bottle. If you look on the bottle, it said for intramuscular use only, and you'll get this a lot from nurses. If you order IV, they say, well, I can't give it IV. You can give it IV. It's due to concerns with QTC prolongation. We'll talk about that with droperidol. It's pretty weak warning on that part. So just take it case by case. If you think it's indicated to give IV, it's okay to give IV. But do know you will get some pushback, and it's okay to give it IM as well. This is kind of another turtle bunny. It's not fast, it's not slow, it's kind of in the middle. You'll see it's not as fast as midazolam, but a little quicker than lorazepam. And then it usually takes a while. So often with just a dose of Haldol, it doesn't zonk people out, but they are in a state of sedation for a little bit longer than other medications. It can be given intravenous and intramuscular. They're possibly intranasal, but not much research on that. And the main adverse or side effects of this is going to be your dystonic reactions and your akathisia. Again, benign things. The only problem with akathisia is usually patients just want to leave the ED, and that may make you have to sedate them more. But these can generally be treated with a little more sedation or Benadryl as well. Droperidol, again, this is kind of the new kid on the block that's actually been around for a while. This is big when I trained. Is my favorite headache medication. And it's the reason why I give Haldol for most of my headaches now, because this was such a useful drug for headaches. But it went away for a while. We'll talk about that in a second, but now it's back. So in general, the dosing is 2 to 5 milligrams IM or IV. It's nice and quick. So it's actually about 3 to 10 minutes onset for both IV and IM. So that's a nice thing if you're doing IM administration. It's pretty fast. It's going to be faster than Haldol. And then it's kind of a turtle bunny. It doesn't last as long as Haldol, but it lasts longer than stuff like midazolam. Our routes, it can be IM and IV as well. And your side effect or adverse effect profile is going to be the same as haloperidol. So with both these medications, especially droperidol, the question comes up about QT interval prolongation. And the reason for this is because droperidol specifically in 2001, it got a black box warning from the FDA. And the reason for this, in the text, it says it was due to QT prolongation concerns. And it said 12 lead EKG prior to administration should be done, and then ECG monitoring continued for 2 to 3 hours after. So it's not very common for us to get an EKG before giving the patient the bowl of Haldol and then put them on a monitor for hours. That's just something that doesn't happen very often, and for good reason, because the research on this was really bad. When you actually look at the research, it kind of comes up as a steaming pile because it's mainly on super high doses of this medication, talking up to 50 milligrams given sometimes. And the QT prolongation in general wasn't significant either. And there's also some concerns about the company itself and their intent, because they were actually releasing another medication at that time. And there's concerns that they may have actually reported some of these cases to specifically get a black box warning and then push the market to their other medication. I think a majority of the cases reported were actually done within the same day. So it's a very kind of sketchy thing that happened. but studies since then have shown no significant QT prolongation. And luckily, the medication came back. The reason it actually went away in the US was because of production issues, and it was no longer available, but now it's back. So do know that it's okay to give, and you don't need to get an EKG in all patients. If this patient is known to have a QT prolongation, it might be safe to get an EKG if you can. I'll often do a quick chart review, but again, if the patient needs it, it's not going to stop me from doing it unless there's other reasons for it. And then ziprasidone or Geodon, something that's become more commonly used in the ED last couple of years. The dosing here is mainly going to be 10 to 20 milligrams IM. This is going to be a much slower onset than many of your medications, and it's also going to last a while. So to me, this is often a second-line medication after I've gained control of the patient. Your main route is going to be intramuscular. It's going to have the same side effect profile as your haloperidol and droperidol. So when we look at those classes, so the benzodiazepines and the antipsychotics, there is a little bit of research to help compare these. And there's two main studies that I like to look at. The first is kind of my favorite of all these studies because it was just really well done. Is it back in 2003? And this study, when I first read about it in residency, kind of changed my practice of how I approach these patients. It was actually a prospective double-blind randomized controlled trial of midazolam versus Haldol versus lorazepam and chemical restraint. So they looked at Versed 5 milligrams IM, Haldol 5 milligrams IM versus Ativan 2 milligrams IM. Versed was found to be quicker on, quicker off, and lower side effect profile. And to me, that's what I want. Again, I want to gain control fast. I like it to wear off a little quicker so I can reevaluate the situation, and I want lower side effects. So that study right there kind of pointed my practice in the direction of midazolam for these patients. And there was another one that looked at midazolam, olanzapine, which I'm not talking about here, ziprasidone, and haloperidol for treating agitation. And what they did is they did all these medications IM, and they found that intramuscular midazolam showed better sedation of agitated patients at 15 minutes. So again, it's just comparing all these head-to-head, showing that midazolam and many other studies as well kind of found to be superior in terms of fast on, fast off, low side effect profile. So monitoring these patients, it's a little different from procedural sedation. I always thought it was funny that for procedural sedation, we have to essentially sign off the rights to our second born and do all this paperwork and stuff. But the second that the patient is agitated, we can sedate them and we're not having to do all this stuff, even though it's the same meds, same dosing. But we should obviously still monitor these patients. So probably the most monitoring we're going to do is we're going to put them on a basic cardiac monitor. And this is probably going to happen after we sedate the patient because it's very hard to put them on while they're agitated. Really what I'm looking at for the most part is my O2 set. That's the first thing I do. That's the first thing we put on last night. There's all this other stuff to happen, but I always stop everyone and say, hey guys, can I just get an O2 set real quick and see where that is? If that's fine, the other stuff can come next. I want to see what their O2 set is. The question always comes up about end-tidal CO2. In general, we do it and recommend it for procedural sedation, but should we do it in these patients? The evidence is not great. What we do know is that end-tidal does provide early warning for hypoxemia. So often your evidence of hypoventilation, so your increasing CO2 will show before your O2 sat actually drops. And that's where it can be useful. But to me, again, these patients are often hard to keep monitors on stuff. If I look at the patient, they have good chest rise and have oxygen on them or O2 sat is good, and I can't get end-tidal on them, I'm fine with that. Again, it hasn't been really black and white shown to improve clinical outcome. So again, the evidence on it is kind of murky. Most importantly, I find it very difficult, especially even when these patients are fully dissociated, they have enough sensory input to know when they're uncomfortable about something. And when something's sticking in their nose, they're often pushing it out with their hands. And I already have a nasal cannula in there often. So I find it to be a little more difficult to actually keep this on the patient. And also, again, I like to personally use high flow O2. And if you use high flow O2, especially around like 10 liters a minute, it actually obstructs the flow of CO2 and it'll make it not pick up on your monitor. And so then you have the nurse constantly coming to you saying the patient's apneic, and you look at the patient and their chest is still moving. So I find it to be a little more difficult. So it's kind of, to me personally, the least important monitor, especially if I can watch the patient breathe. But my practice in terms of monitoring, I give the medication and I stand at the bedside. We're often very quick to give it and walk away. But first, especially in the first couple minutes, the research shows in procedural sedation that serious adverse events usually happen the first 5 to 20 minutes, especially in this first 5 minutes. So what I do is I give the medication, I sit at the bedside for a couple minutes. I make sure they continue to have chest rise. I make sure their oxygen looks good. I walk away. And I'll usually come back 2 to 3 more times those first 5 to 10 minutes and just spot check them. Because like I said, procedural sedation, we're giving the exact same dose of ketamine and drugs and procedural sedation, and we end up having one-to-one nursing and end up having doctors at the bedside. With these patients, we often just walk away, but it's the exact same dose of medication we're giving, often with a higher risk because they actually have other meds on board. So again, I go back a couple times the first 5 to 10 minutes just to make sure everything's looking good. But again, if you know the mechanism of the drugs that you're giving and you haven't given multiple meds that might kick in down the road, you'll be able to predict how these patients will do. I'm going to touch on a little advanced stuff, and then we'll get into some quick cases. I'm going to talk about continued sedation. So we, again, my focus is gain control, and then reevaluate the situation and tailor your treatment from there. Sometimes these patients need one dose. You just got to do an EKG or something, or just calm them down, and then they can be on their way. But often we do need to sedate them for a prolonged period of time. And I'm here pushing midazolam and ketamine, knowing that those effects will wear off in 30 to 40 minutes. And so we may need some longer sedation. So then you just have to think about, well, what's your goal? Our goal can be just to metabolize medications or drugs or alcohol. Our goal can be to talk to ETU. Our goal can be to discharge to jail. Our goal may be to admit to the psychiatric unit or the inpatient side. So that knowing your goal will then determine what you do next, because you have options. You can add the same medication. You can add a longer acting medication, or you can actually do an IV infusion of a medication that we'll talk about in a second. So in this case, where I'm just kind of trying to control the acute phases of craziness, just to get this patient to talk to ETU or maybe metabolize some drugs that I think will wear off in an hour or two, then I might just kind of spot check and give small doses of midazolam. So in 20 minutes, they start riling up again, I'll give another dose and chill them back out, knowing that, hey, I just want this patient to be calm enough to talk to someone. Or at that point, if I think there's an underlying psychosis, I'll give my Haldol, my droperidol, or my Geodon, knowing that by the time the midazolam wears off, those will be taking effect. If I have a different goal, maybe my goal is to admit this patient and either to the ICU or inpatient status, and I just want them to be chill. I've done my workup. I've got my workup. I don't need anyone to talk to them. I know that when they wake up based on how they came in, I know they're going to be crazy and I want them to stay down. Then I'll give either additional doses of my ketamine or something like Ativan. That's when I start adding stuff like Ativan on, or again, Haldol, something longer acting, knowing that I want them to be chill for the next couple of hours because they may be in the ED for the next couple of days while they await a room upstairs. So sometimes our goal is longer sedation, but we want it to wear off fast. So if I have a goal, again, of metabolizing a med, drug, or alcohol, or I want them to go to jail, or I may want them to go to the ICU, but I don't really want to intubate. They don't meet intubation criteria, but I want them to be able to like wake up fast so they can reevaluate them. I will sometimes reach for an infusion. Again, a good example of this is that super violent patient comes in, I give them ketamine, I gain control. I know they're going to jail and they have a history of this. I need to do a quick workup. I need to get a head CT on them possibly. But the second all that's done, I want them to be awake enough to walk out the door to jail. I'll use something like dexmedetomidine and propofol. And so the reason I like these is because I can keep them continually sedated. I'm not redosing a bunch. And then when their workup's ready, I take it off and within 5, 10, 15 minutes, the medication's out of their body and they're ready to go. So just think about these a little more advanced medications. We don't often use propofol infusions in extubated patients, but is a completely doable thing. Dexmedetomidine is something that many of us haven't used, but just talk to us on shift about it if it's a good choice, because essentially it'll just induce a state of sleepiness and not fully sedate the patient, but it just makes them want to lay in bed and sleep. So with all that in mind, we're going to go through 3 quick cases and be done. So this first case here, this is your psychotic patient. So patients we see all the time. He comes in. The first stage of this patient, he just wants his Haldol. Now, if that person's talking to you, they're nice and calm. He just wants his Haldol. He's been off it. Great. Give him his Haldol. Give him his droperidol. Let him chill. Do whatever you need to do. When they kind of turn the corner to that scary psychosis, they're not overtly violent, but they're not really cooperating with their workup. They're making things a little bit difficult. They might be like Dr. Patel was talking about, refusing workup, but in your mind, you don't think they have that capacity, but they're not throwing punches and trying to kill people. Then you want to go ahead and probably add on some other medications. So with these patients, my initial stage to gain control, when I can tell they might kind of go off at any moment, and I don't want to wait for my Haldol to kick in, my go-to for this is midazolam, either IM or IV. Often I can talk to these patients and say, hey, look, sir, ma'am, do you mind if I get a quick IV in you just to get some blood? And often like, okay, that's fine. And while I'm flushing the line, I go ahead and put 2 to 4 milligrams IV. But if that doesn't work, I'll usually do IM. The IM dosing of Versed is very important. Again, we often fall back to the 5 and 2. But if you're giving 2 milligrams of IM Versed, and this is something that happened last night, you're often grossly underdosing the patients. You really need to push up more to that 6 milligram IM. And the reason I put 6 is because in our department, it comes in 2 milligram vials. So it's often easier to pull up than 5 milligrams. But it is okay to give up to 5-6 milligrams IM. Many places and agencies will do 10 milligrams IM up front, but I think it's safer to start with 5 or 6. And what this does, it chills that patient out and it allows you to start your workup. Again, these aren't the super violent patients, but I want to be chill enough. I can put some soft restraints on him so that he doesn't pull his IV out. I can start my workup. At that point, decide, do I want longer sedation? Again, this guy, I know he's psychotic. He just needed to chill for a little bit. So at this point, that's when I'm going to go ahead and give my haloperidol or Geodon. So by the time the Versed wears off, he has what he needs in his system. So next patient, this is that violent, agitated patient. That violent patient that is a true threat to the safety of your staff or other patient or themselves. These are the patients that I advocate for ketamine up front. Because again, sedatives make a patient slow down, ketamine makes the patient stop, and I want this patient to stop. So while we're wrestling this patient down, trying to gain access or get TATs on, this is when I'll try to give ketamine. So often we're giving intramuscular. I prefer to give IM just because it's much quicker, but if you have to give, I prefer to give IV because it's quicker. But if you have to give IM, it's 4 to 5 mg per kg. Generally across the board in adults, I just go ahead and pull up 400 milligrams. And go ahead and give that. Again, knowing that if I go up on my dose of ketamine and I go over the dose or recommended dose, it's okay. You're not going to have adverse effects. And make sure you're reaching for the right formulation. The bottle on the right is the 500 milligrams per 5 ml. That's what you want if you're doing IM. You don't want to be doing the other bottle we have, which is 200 milligrams per 20 mLs, or giving 100 milligrams IV. Or like I said, in some instances, rarely I've had to put it in IO and give it IO. And I would give the same IV dose for that. Again, that gains control. That puts you in a position to restrain the patient, get your IV access, get whatever monitors you need. At that point, I personally will usually put high flow O2, either non-rebreather, but I like the high flow O2, and put that in 10 liters and then just kind of sit at the bedside and watch the patient and see what happens. I can then tailor my treatment. Again, I can now go back to the chart and look, okay, does this patient do this before? Are they underlying schizophrenic? Are they usually on a sympathomimetic? What's JSO telling me? So I can tailor, do I want to just give one more dose of ketamine and see what happens? Do I want to wait and see him wake up and see what happens? Or do I want to give an antipsychotic? Often I'll just give that first dose of ketamine and then wait to see what happens. Especially in some of these violent patients, you'd be surprised how many times that kind of resets their system and they wake up a little bit nicer than when they went down. Yes, often we do have to resedate them, but it at least gives them a chance to talk to you and tell you what's going on. If they come back up swinging and yelling, cussing, I'll put them back down without a blink of an eye. And then another option, which I'll also do, just given the benefits of Versed and how quick it is gain my control with Versed up front and then dissociate with ketamine. The reason I did this, because for a long time we didn't have that highly concentrated ketamine, so we didn't have a good IM route. So my practice that I got into was giving 4 to 6 milligrams of Versed up front. And then once I gained control, then getting an IV and giving my ketamine. So I think that's a viable option as well. And finally, our last patient, not chemical restraint so much for psychosis or agitation or violence, but chemical restraint nonetheless, and a very difficult one. This is a patient that I actually had with Dr. Mandati, the PEDS fellow, a couple weeks ago at North. It was a 150 kilogram 14-year-old with severe autism who would not let anyone touch him. He was sobbing. Mom was in the corner sobbing. Mom refused to allow him to be restrained to get IV access. She was very nice. She was just very worried. And it was a potentially very dangerous situation because despite this kid was 14, if he came at me, I wouldn't be here today. He could have easily taken me down. So we had to approach this, given the emotional and psychiatric issues going on as well. We had to go at this very carefully. So Dr. Mandati and I kind of took a step back and came up with a plan. And so first we wanted to gain control, obviously, like I said before, and then figure out what our goals are. So our goals were safety first. We want to keep the patient safe. We want to keep ourselves safe. We want to look out for mom. Mom is freaking out. Mom's in the corner crying. Mom's worried about her child. And so we want to give her a sense of safety and allow her to be involved in the care and restraint as well. We want to do a workup. This kid unfortunately ended up being a new onset DKA. And then we wanted to get him to Wolfson's through kids care. So knowing that, we knew we were going to have to gain control, and we knew we were going to have prolonged sedation, because at no point is this kid going to wake up normal with normal mentation, able to walk and talk and follow commands, because at baseline, he can't do those things. His normal is to not be able to do those things. So we knew we were going to need prolonged sedation. So our first step was, again, gain control. And the way we did this, we did 400 IM of ketamine, which in him was probably underdosing, but we just wanted to get something in him quickly. We knew this wouldn't fully dissociate him, but at least start calming him down so that we could get better dissociation. So we actually did, we each snuck up on each side with 200 milligrams, and at the same time, injecting each arm, stepped back and brought mom in to hug the patient and hold him. That chilled mom out, chilled the patient out, and allowed that to sit in for 5 or 10 minutes. And we could see he started dissociating and chilling out. At that point, the nurse and tech were able to come in and place an IV. We were able to get him on all of our monitors. We reevaluated the situation, realized we wanted to push him more into full dissociation. So at that point, once we had an IV, we gave 200 milligrams more. So at this point, it was 400 IM and 200 IV. At this point, he obviously reached a ceiling effect, full dissociation. We were happy we were able to kind of go from there. So we can control the situation. We kind of reevaluated. Again, at this point, we got all of our workup we needed, got him on the monitor, Entitled CO2, and we then tailored our treatment. And we knew, again, at that point, we wanted to keep mom comfortable. We wanted to keep the patient safe and get him to kids care to Wolfson's. So at that point, we actually chose dexmedetomidine or Precedex, put him on that infusion. So as the ketamine wore off for the next hour or so, he had dexmedetomidine on board. And it worked absolutely beautifully. We were able to take off all the other meds. He only had that running. And per Dr. Mandotti and the PICU team, they actually kept him on that for a couple of days, and it worked well for him throughout the stay. So to kind of wrap things up and cover the important things, again, remember, specify, tailor, and minimize. Don't just yell out 5 and 2. Specify exactly what you need, tailor it to the situation, and don't give 2 or 3 meds when you can just use one to have the same effect. So please avoid the 5 and 2. Don't get me riled up by yelling at 5 and 2. Be a good doctor, gain control, reevaluate, fine tune. I think it's how you need to approach every procedural sedation and every chemical restraint. Pump the brakes on intubation. It's very rare that we have to truly intubate someone for chemical restraint. It does happen, but it's pretty rare. Most of the time, if you use the right medications, the right dosing, you can control these folks. And there may be other reasons they need to be intubated. Use this time you have to learn this stuff. You're going to go out to places that may not have certain medications. You may just 5 and 2 everyone when you go out, and that's fine. But I want you to have handled, dosed, administered, seen the effects of all the medications we have in the department. Because you may find in 5 or 10 years, a lot of these medications are becoming first line. Or again, you may not have certain meds when you go out to other hospitals. There are EDs that can't administer ketamine. There are EDs that can't administer propofol. So you need to have all of these meds in the back of your mind, have used them at least once before to know the effects and be comfortable with them. And then finally, I do want to give a quick shout out to who I call the 3 Farmigos, Mark Schreiber, Joe Spillane, Patrick Aronson. I rag on these guys on a daily basis, but the honest truth is they are one of the most valuable assets of our department. They're right across the hall. If you have any questions about meds, go talk to them. This is their job to know these things backwards and forwards. And I think they have a good grasp of current literature and evidence for these medications. Go talk to them. If they tell you you can't use Precedex, tell them wrong and just push on. That's all I have for the lecture. I welcome any questions, and thank you guys very much. I'll try to unshare.
Andrew, I got a quick question.
Yeah.
If nobody else has one, I can't see. Somebody else has asked one. I can wait. You know, where we had issues with great presentation, by the way. And obviously, I'm one that agrees with the go big or go home theory of managing patients who are violent in the ED. We need to get control and control quickly. When we've had trouble with the patients coming from rescue and we went to that protocol, the one thing I wonder, how do you take into account and where we tend to be challenged with these patients that ended up getting intubated? And that is a problem with the going big on ketamine without, especially not being done by the physician at bedside, is also not knowing the concomitant, what other meds that they're on. right? Or what other drugs have they taken? Because most patients, yes, they're maybe psychotic, but a huge percentage of them are also on some type of other drug. So that becomes an issue. And when you sedate them, you get this almost doubling effect of the respiratory depression when you didn't expect it. So how do you address that? And with the pre-hospital utilizing those large dosages, and also for even what would you recommend for our residents, given that some of these patients may present acutely without pre-hospital management, but at the same time recognizing that there's a concern for crossover from other drugs.
Yeah, so all the pre-hospital literature did show a correlation of increased intubation in patients who are known to have concomitant benzodiazepines. So in the agencies where they gave Versed up front, then gave ketamine, they did have increased intubation, and that did actually seem to be due to respiratory depression truly, and not just provider discretion. So that's obviously important to get from your crew. What else did you give them? Because you do need, I don't think if they say, oh, we gave 10 of Versed and 500 ketamine, the next step for you isn't, okay, let's intubate. The next step is, okay, let's watch this patient closely. Let's not put them up in bed 15. Let's watch them closely. The other thing is, and then we did have a real problem with this in your cases you're talking about when JFRD first launched ketamine, was making sure wherever you work, if you have communication with EMS, making sure they're giving it for the right reasons. Because the reason why some of these patients were intubated were their post-ictal combativeness. And so they're post-ictal combative. They gave them 500 ketamine, and now you're presented with a patient in recess who you're not sure if they're still seizing, because they were originally a seizure patient, and now they're dissociated. So that is, we immediately went back to JFRD that week and said, hey guys, congrats on your med, but let's make sure we're giving it for the right reasons, because now we're intubating patients because you have a provider who doesn't know if they're still seizing. So that is when having good communication with your EMS folks and maybe have good opportunity to say, hey, let me educate you on the current evidence and why we should be using this medication.
Thank you. One last maybe a comment and question, because I think that that actually was addressed, is the issue that I think we don't do a good job of, and I'm interested to hear your comment on this in the ED. And I know you addressed in the talk a lot of management of patients. I'm a big fan of droperidol. I've used that for many years, and I like it. I like ketamine too, but I really like droperidol for a lot of these patients who aren't overly aggressive, because I think they wake up quicker. I'm able to manage them for all the reasons you pointed out in the beginning. I've always had the issue with the B52 thing as well. So I'm wondering though, would we not be better off a lot of times if we recognized early agitation as an indication for medications that are oral, versus waiting to these patients escalate to a position where now, yes, they do need IV drugs or they do need IM medication. So that's an area that I think we could do a better job of as the attendings, and also as the residents, is when we see these patients starting to get up out of bed, starting to get antsy, starting to get kind of not following the commands like we think, that maybe that's an early indication that if we don't do something now, we'll be doing something a lot more aggressive later. Your thoughts on that?
Yeah, I 100% agree. I am a firm believer in a lot of the agitation we experience is iatrogenic. When someone starts getting out of bed and seem a little cranky, and you walk up and yell, "Sir, get back in bed now," and suddenly you have 5 security guards behind you, you rapidly escalate the situation. And I think especially these patients may have been in the ED for a while now, and they've missed their home meds. I think it's a good chance to go back to the chart, see what they do, see what they have on board, or see what they should have, make sure they're up to date with their own current meds. And then I'm completely happy with oral benzos and oral antipsychotics, especially again, those early phases. If you can avoid the restraint and avoid the chaotic nature that we can sometimes provide and produce, I think a definite viable option.